For our audience who may not entirely know what REDUCE is, both of you are on the steering committee. You want to give a synopsis of the study, design, and results?
Well, so we go back. It was an interesting in that this study looked at icosapent ethyl, and there's been, we think of fish oil, and Steve, I think just as a correction, there are no OTC. Those are supplements. Yeah. The ones that you see in the pharmacy, those are not regulated in the same way that an OTC product is for it. So, but there basically we had a mixture of DHA and EPA that was approved by the FDA. With that, a lot of lipid studies were done with that. Those were used at 1 gram studies. GC had some excitement for it. Then EPA was studied for very high triglycerides, for mixed dyslipidemia. Looked to be effective in regards to reducing triglycerides, and at which time, which was, to me, was interesting because we started this back in the 1990s working with the first formulation, and then the second one is they decided to do an outcomes trial. And so Mike, we were all impressed with that, and because it was not a big company and they only had one product. And Steve, you pointed out no one had ever done a trial based upon high-risk patients with high triglycerides. So basically documented ASCVD or diabetes over the age of 50 with the one additional risk factor. But Deepak, I want you to present the results because you do it better than anybody else.
Oh, well, that's kind of you to say. So 8,000 plus patients as described, secondary prevention or diabetes and high-risk primary prevention. So a bit of a hybrid trial, and what was found overall was a 25% reduction in major adverse cardiovascular events, including things like heart attack and stroke, revascularization, yes, cardiovascular death as well. So a pretty consistent result in terms of all those components, also hospitalization for unstable angina reduced. So overall, the trial was positive, subgroup showing consistent benefit pretty much across the board. So it was a positive study.
Deepak, I wonder if we could maybe circle back, because there's a whole class of drugs we haven't talked about.
Yeah, no, there's a lot we need to cover.
And the PCSK9 inhibitors.
But just before you do that, I'm just going to turn to Jamie, because you were talking about another trial that is a confirmatory trial you worded, and I think strength is incredibly important scientifically. But Jamie, in your role, not just as a physician, but as a leader in the National Lipid Association, the current president, what are your thinking in terms of implementation and actionability of the REDUCE-IT findings? The guidelines from the NLA have come out with a class 1 indication, which in general means in a patient that is an appropriate candidate, do it.
Right, and our recommendations mimic that of the Europeans and the American Diabetes Association. And so while your trial data was not available for the recent iteration of the 2018 guidelines here in the US, I think the series of recent recommendations all fit with the enrollment criteria for the trial. Now, how the FDA comes in on that, on the indication side, will be interesting, but clearly in this high-risk population of patients who meet the triglyceride findings on the enrollment, I think adding 4 grams a day of icosapent ethyl is a reasonable intervention in the patients that meet that recommendation. Now, the question is, do you use it instead of some of these other drugs we're going to talk about, or on top of as a side risk reducing?
So Jamie, one thing that maybe to bring it kind of back into focus as the clinician is that, so you start off in a high-risk patient, we talked about this pretty extensively, you start off with a statin. Yep. That's all the guidelines say the same thing, and then you can try to make sure you've treated them aggressively enough, depending upon their risk, to get the LDL down. At which point you need to remeasure the lipid profile. Now, we said now, there's this concept of a threshold, but basically if their triglycerides are high, we've talked about, then that would be a patient one could consider EPA, maybe we'll see in the future other agents with it. But the other one ends up, don't forget about the LDL.
What was the LDL in REDUCE-IT? It was low, right?
Yeah, the average LDL around 70-ish, you know.
So their LDLs were well treated.
With benefits that were consistent across the entire range of LDL we studied.
So as Christy
40 and
points out,
100.
this is not in lieu of treating LDL.
No, I think they're completely complementary
exactly.
pathways. I think if the LDL is high, get it as low as you
Right.
safely can.
So that's what comes up, though, is if we looked at and reduced it, people, I think it was 6% on ezetimibe. So in the other trials that have been done, looked at, they basically had, they opted, they had a threshold, they had an LDL of 70 or higher, non-HDL and Deepak. You were involved with a lot of these other, but the programs, but it's interesting. You know, it's a field. We look at chronic disorders, hypertension. You know, everybody uses combination therapy for hypertension. Diabetes, everyone uses combination therapy. We get to lipids, it's just people, if they even use one, is that basically there's one drug, and we see in all these trials it's around 6 to 8% ezetimibe usage, very little add-on therapy in terms of fibrates or prescription omega-3s. So I think it's time to, you know, when we talk about LDL now, but we think there's in an era of where we're using combo therapy to knock down blood pressure and diabetes. It's not happening for LDL either.